From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
Welcome to episode 242 of the Crisis Jam. I'm David Covington, your host for the day, and we're thrilled to have Dr. Madelyn Gould with us as our featured speaker. I first heard her in probably December of 2004, if I remember correctly. It was joining the Lifeline steering committee as we were making that transition from 1-800-SUICIDE to the Vibrant Emotional Health. And Maddie and John Califat and Brian Mashara had been doing this groundbreaking work that would set the foundation for impact. And we're going to hear a lot more about that evaluation that has been going on, Maddie, since 2001, 2004, as that transition, and the first published paper in 2007. So more to come. We're glad that Maddie is here. We did a sound check in the backstage pass. We also played an amazing choral, Will You Hold the Hope for Me? That, again, if you join us early, that's some of the content you'll get. Ursula Whiteside recommended that video from NHS in the United Kingdom, which we can share again in the chat. But we also asked folks to share a recent win. And I was talking about our All Feelings Welcome shirt that Kristen Ellis designed. I wore this at the HMA conference in New Orleans a couple of weeks ago. And that care that feels like care sentiment and vision comes through. I'm really excited about that. Thank you, Kristen. If you want to know more, you want to sign up for our newsletter, stay in tune with what's next on the Crisis Jam. Season 6, we've made it as simple as possible. It's crisisjam.com, shaping the future of crisis response together. Register for, we want you to join this Zoom, but if you're out there live streaming on YouTube, we're glad you're here as well. But the chat and text we're keying off of as hosts and those of us who are presenting is on the Zoom, and you get to that by registering through the crisisjam.com. The link for the live stream is there, and our newsletter, which gives you updates on what's coming next. You can also see what's been up, and of course, I've still got up this amazing Battle of the Bills from Senator Tina Orwell and Rep. Ellison, as well as more information of the PowerPoints, trivia questions, and more. You can also visit us on YouTube at my 5 Lanes One Road to Recovery website that has all of this content going back to the beginning of the Crisis Jam when Richard McKeon launched this convening and this community back in 2020. So we'll have more on that. But today's breaking news, I want to start with, we had Dr. Carol Olson from Valleywise on a couple of weeks ago about a referendum here in Arizona. We do have news that of those various referendums, the one in Franklin County, Columbus, Ohio, passed. This is fresh off the press this morning from the Columbus Dispatch, that the property tax levy to up public funding for mental health center, and this specifically this Franklin County Crisis Care Center, passed. From what I can tell in the news, the Valleywise vote, it's up by 5,000 right now. It's really tight, but it looks like that Prop 409 might make it through. Fingers crossed for that one as well. But today, Dr. Ursula Whiteside, if you're with us, if you can come on, I want to talk a little bit about last week's episode and mental health apps and AI. And we've got a FDA convening committee meeting this week that is looking for public comment. But to lay the stage for that, I'd like to play a minute of last week's mental health apps and AI with host Laura Evans, Dr. Stephen Schuler, and Dr. John Draper.
That is very concerning.
Yeah. I would love to just highlight that Ursula was absolutely instrumental in bringing folks together and in drafting that article and making sure that it got public attention and got directly to OpenAI. So, and highlight and publicize what's needed in terms of the behavioral health care risks.
Yeah, well, thank you so much, Dr. Atkins and Dr. Whiteside. very concerning, lots of areas and guardrails that we still need to discuss. And against my better judgment, I'm going to give Hal the last word on this. Hal, any thoughts?
Very insightful conversation. It's encouraging to know that even after all this progress, the trust issues remain mutual.
Well, thanks, Hal. I deeply regret going back to you.
So Ursula, I don't know if you've joined yet. Jump in if you haven't. And if Ursula doesn't join, Dr. John Draper, you might actually jump in here as well. We're going to put the link into the chat, but the Digital Health Advisory Committee meeting is tomorrow. And I'm not seeing Ursula. John, we want to make sure, and you were terrific. Of course, we just saw Dr. Atkins and Dr. Whiteside in the roundtable following your fireside chat. Amazing the opportunity we now have. 1 million people a week sharing explicit thoughts of suicide with ChatGPT. Another nearly 600,000 appear to be in a psychiatric emergency, a manic episode, a psychotic episode, a substance use crisis. We've never had this kind of opportunity, but we're out there without the guardrails yet. So you want people to make a public comment.
I do. Ursula had mentioned that we had put together this group letter that Dave Atkins had noted, and this went to OpenAI. OpenAI took some of those recommendations. They did make some changes that were significant, but we can't expect OpenAI to police themselves or to be such an industry leader that all the smaller companies that are innovating with AI and doing things not necessarily because they should do it, but because they can do it, that we need to have some kinds of federal regulations that oversee everything that all AI is doing, including in the health and mental health space. And this is our opportunity specifically to say something to the FDA in this upcoming hearing. And I think that you can register public comments up until around December 8th.
Okay, great.
There's a link. The link is probably going to be in the chat. You can take a look at that. But please follow up with that and make sure that if you don't have time to attend the public hearing tomorrow, that you do have time to register a public comment in writing. And it's important that they hear our voices.
John, if you can see if we can't get a link to the open letter that Ursula Whiteside put together with so many other leaders. Let's see if we can't get that in the chat and some recommendations for comments for people to
Great
put
idea.
in. So thanks so much, John. It's time for our hot seat. And today we've got Dr. Margie Balfour, a longtime crisis champion, and Helen Luttrell from Behavioral Health Link, another amazing crisis leader. Had a room full, Helen, at CrisisCon. I had to sit along the wall for your supervision session. So, Margie, I also missed the days of the Crisis Jam memes.
Oh, well, I can bring memes.
Well, since Margie is here, first of all, Margie and Helen will both get a coupon code to go on the crisisjam.shop. All feelings welcome, as well as a host of other Crisis Jam and 988 swag that they can pick. But since we've got Margie and we're talking memes, I've got a meme for the day. Now look, Margie and Helen are super titans in this space, but anyone can jump in this Crisis Jam trivia hot seat, and we hope you will, just like this little dog. Now, he may have panicked a little bit, but we'll give him a shot. He's being encouraged to walk down the steps.
Come on. Let's go. Come on. Come on.
He just disappears. So, yeah, but look, team, we're encouraging you. Take the leap. You won't regret it. How'd I do, Margie? Margie, you used to do a meme a week. Is this okay?
Yo, that's a good one. That was cute. Everybody loves cute animals.
Yeah. So all feelings welcome. Jump in. Let's look at today's question. And look, we're so proud of Dr. Madelyn Gould spending some time with us. She was last on the program in 2021, back in episode 56. So it's been 4 years, Maddie, since you talked about, and you've done further work, which you're going to update us on today. But which of the following innovations was fueled most by Dr. Madelyn Gould's Lifeline evaluation work since 2001? A, mobile crisis response teams, B, follow-up care, C, the Veterans Crisis Line, or D, 988 National Crisis Redesign? So Margie and Helen, talk amongst yourselves there while we put up the poll.
Well, so when you mean fueled most, I mean, because I know that she's done a bunch of studies on the Veterans Crisis Line, and part of that being and I used to work at the VA as a resident. I love the VA and the fact that they have all this data available more than anybody else has, which makes it just ripe for doing studies. But I also know that there's been work on the follow-up care and the importance of those caring contacts and partnerships with, back when I was in Dallas, we were actually part of one of those studies, that was when ERs partnered with crisis lines to do those.
Oh, so you're one of the early cohorts. Helen, what do you think is,
yeah.
I mean, yeah, before the answers even came up, I was like, follow-up. It's got to be follow-up, just because of the massive impact Dr. Gould's had in follow-up. And so my heart says go with the, first thing that you thought. And
let me give you the audience. The audience has been, it was a tug of war the entire way, with National Crisis Redesign in 988 leading till the finish line, but right at the end, follow-up care came out ahead. So Margie and Helen, what's your final answer? And this is a duo. Y'all are a team. Y'all got to come up with a joint answer.
Okay. Margie, do we want to lock in B, or do we want to go with the audience?
I think B. I mean, it's like, so National Crisis Redesign, I mean, her work has really shown the value of 988. So I don't know if that's what this answer means, is that, so the nation hopped on board with creating 988 because of the work on the Lifeline.
It has fueled, the word fueled is getting me getting me up, and maybe I'm doubting myself and thinking D, but I don't know.
Our first instinct was B.
Let's go with B.
All right, so B's the final answer. B is my answer. So I wrote this question, and I was thinking, and Margie, you guys are so good at this. This is like having Richard McKeon on.
Well, I've taken a lot of multiple choice tests in my career.
I wrote B, and this is what I was keying off of. These are the key elements from her work: significant reductions in callers' suicidal intent, hopelessness, and psychological pain during the course of a call. Follow-up context led nearly 80% of callers to report the support stopped them from killing themselves. Now, I shared this question with John Draper last night, and he said the answer is D. And look, John makes a really compelling argument that I think is an interesting one, because I remember back in 2002 going to suicide prevention state coalition meetings and them wanting to move the money from crisis lines somewhere else. They didn't think crisis lines were valuable. They didn't think we talked to people who were really at risk. If we did, they didn't think we made an impact. Now we knew we talked to people at risk, but we didn't have data around that. We didn't have research around it. And John said Dr. Madelyn Gould's evaluation proved these lines save lives and paved the way for a national system and ultimately 988. So I think they're both great answers, B and D, which are, and again, your work has impacted all four of these, Maddie, but the answer was most fueled. And I think it's probably D now that I would have said B for sure, you guys, but I think John's right. And in fact, to the point that we want to give a special visionary leader label here. We gave Richard McKeon this award in Amsterdam last year. Richard said at the Live and on Location event back in March that Steve Elison was the one person. There's been thousands of us who've lifted up 988. But he's the one. If you pull him out, it doesn't happen. And I think John's arguing that if you pull Maddie out, maybe it doesn't happen either, because Steve can come up with the idea, but we gotta have the ground tilled. So actually, Richard's coming out to Phoenix for he's a national finalist in tennis duos. So I'm going to ask him tonight what he thinks about this, Maddie. I think he's gonna say the same thing. So. Great work, Helen and Margie. Okay, you got one more. You got the over under. You're off to a great, scorching start. Let's see if you can keep it up. I'm going to play, to set the stage for this, I'm going to play the Crisis Jam anthem. This is our mission at Crisis Jam. So that mission is based upon the three-part core services plus follow-up, Maddie, of someone to call, someone to come, and a safe place for help. But that's not the only strategy out there. Now, we use that strategy at Crisis Jam. We used it in the Crisis Now report. The SAMHSA guidelines use that. But Dr. Joe Parks and the National Council put out a roadmap. Margie, you were a key leader in that roadmap. And it took a slightly different approach. Paul and Dr. Joe are going to debate that next week. But Dr. Parks is going to talk about the elements of a continuum that come up in the roadmap that doesn't just focus on 3 core services, but focuses on 11 that was in that national roadmap. So that's going to be the debate next week. But our next question isn't over under.
For this.
I'm sorry for interrupting, Cookie Monster, but it's time to cut the cookie. And let's talk about this idea of a continuum. When did that first emerge? This is going back to the timeline when crisis, we were crisis when crisis wasn't cool. We're going to go back to another one of those in the Crisis Innovators Timeline Edition. Jennifer Battle, Vice President of Community Access and Engagement at Harris Center, is also co-chair of the 988 Lifeline Network Center Committee. There's Jennifer. Thanks for joining us. Jennifer's going to be quiet here because she knows the answer. Harris Center was one of the first crisis organizations to focus on a continuum. What year was their matrix visual introduced? Laid the groundwork for things like the National Council's roadmap. Margie, you want to do the year or do you want to pick over or under?
I mean, I could guess a year.
Guess a year, Margie.
So, let's say 2010.
2010. So Helen, earlier or later?
I feel like the Harris Center is very innovative. And so, but I'm like, what year was their matrix visual? I'm like,
let me give you a clue. Let me show it
I'm
to
like
you.
thinking maybe it was earlier, but that's the visual.
That's the visual. And look, I don't know for sure this was the year it came out. This was the year I saw it.
Okay. Jeez, now there's clues.
I'm
pixelated text.
Yeah, I'm gonna stick with earlier.
Yeah. So let's Jennifer, I was looking for a picture of you and I found this spectacular picture on your Facebook page. You can see everything is fine while the building is burning. Jennifer, we do crisis care. But hey, Jennifer, what did you think were you around when this visual came out? Tell us about your thoughts. How would you have answered this question?
I would probably say that was 2004, maybe. We really went, 2003. We really went big with our comprehensive psychiatric emergency program, CPEP model, starting in 1998 at the agency, and had my original program, the Helpline/Crisis Line, went live as the second to final component of that CPEP in 2003.
Terrific. So let's go back to that pixelated rotary phone, but the elements of this, Greg Graham, who was my partner in crisis work at the time back in 2003 when we first saw this, we were captivated by this, Jennifer. Of course, we were watching. We talked a couple of weeks ago about the technology that BHR was doing. We were doing tech work, but this continuum, this matrix, we thought was really the future. And Margie, it's been very much that. Margie and Helen, terrific. But hey, let's look at, Jennifer, you said that graphic sucks. Now, back at the day, it was amazing. But today, let's see the graphic of today at Harris Center.
Ooh.
What's your favorite part, Jennifer?
Well, I mean, I have to go with the, a couple of those that are my pieces, which the 2003, which was the beginning of our 24/7 crisis line. And then, of course, for this particular crew, I got to go with 2015, which was our very first in the whole United States 911 crisis call diversion program with co-located crisis line responders inside of Houston Police Department dispatch. And then, 2022 for the newly envisioned 988 piece, but proud of every single piece on this continuum and all the little other pieces that are in the middle that helps us serve people in our community.
Thanks to Jennifer and Helen and Margie. Great stuff, everyone. And now to our lead story, Dr. Madelyn Gould. And Maddie, we ran over a few minutes, but we're going to give you your full 15 minutes.
Okay, thank you.
For impact of Lifeline services and evaluation report. Thanks for joining us.
Thank you. All right. So thank you for inviting me. I am so delighted to be with you all today so that I can share our most recent findings. And this was published this year in Suicide and Life-Threatening Behavior. It's an open access paper, and I'm hoping that the link is in the chat so that for those of you who want to follow along, you'll be able to open the paper. And so next slide, thanks. So, yep, I just wanted to first list all the co-authors, because as you all know, this work requires a lot of people, and Allison Lake, who's been a longtime collaborator, is here today on the Crisis Jam. And these other names may look familiar because we've co-authored many papers together. Next slide, thanks. Next slide. Thank you. The primary goal of the project was to assess the effectiveness of the Lifeline for suicidal callers. That this study focused on suicidal callers, not other crisis callers. And that the main outcome measures included the caller's perceptions of whether the crisis intervention stopped them from killing themselves, and whether the callers reported that the crisis call was helpful to them. And then a secondary outcome was the caller's suicide risk status in the days or weeks after the crisis call. And we also examined what and whether crisis counselor behaviors were associated with the caller's outcomes. Next slide. So the evaluation used all these assessment methods, but for the paper and the focus of today's presentation is on the information that we obtained from interviews with the callers. That the other sources of data will be the focus of future papers. Okay, next slide. So this slide is a brief summary of the project, and we'll keep it on as I provide some more details about the methods and discuss some of the main findings. And then I'll have several subsequent slides to give you some details regarding other results. But I wanted you to get some information about who the callers were, and that for those of you who have the paper open or look at it later, this is table 1. That about 42% of the callers were between the ages of 18 to 24. We don't interview anyone who's younger than 18. Another 30% were between 20 and 34. So, it's a substantial proportion of callers who are, who are relatively young. About 59% are female, 5% were Asian, 14% Black, 65% white, 15% of Hispanic origin. And that individuals at high risk for suicide, which is not going to come as a surprise to you, call the crisis lines. And the high risk is indicated by the high rates of prior suicide attempts that we found among them, which was 52%, and high levels of intent to die, to act on their wishes to die at the time of the call. And this is consistent with our earlier 2007 findings as well. The data was derived from interviews with 437 suicidal callers. They were recruited by their crisis counselor at 12 centers representative of the network. We conducted the interviews between April 15th, 2020 to August 15th of 2021. And that we conducted this study because there was limited information on suicidal callers' perceptions of the effectiveness of their Lifeline calls. Our original study, which was published over 15 years ago in 2007, examined changes in the caller's self-reported hopelessness and psychological pain and intent to die during the call and 2 to 3 weeks after. But the extent to which their calls help them and stop them from killing themselves was not, we didn't examine that in 2007. So that this current study was to update the estimates of the Lifeline's effectiveness using the really what we consider now important outcomes of callers' perceptions of care that we and other people are using in most evaluations. So that the main finding is that this is the second bullet here. The vast majority of suicidal callers thought their crisis calls helped them, nearly 98%, and stopped them from killing themselves a little or a lot, which is about 88%. And nearly 70% reported that the call stopped them a lot. And that the callers' perceptions of counselor behaviors in the domains of fostering engagement and connection, collaborative problem solving, and safety assessment and management was strongly associated with their perceived effectiveness of the call. Next slide. This is now, so these next few slides are just those were the main findings, but there are a number of additional findings in the paper. I laugh because I always cram so much into a paper. And so this is first about recurring suicidal thoughts after the initial crisis call. And approximately 41% reported, and we interviewed them on average 13 days after their initial call, so that's when they reported it to us, that they had thoughts of killing themselves since the call. This reinforces the importance of providing follow-up calls, which was on that earlier question. And so it's still, it's just very important not to give up, even in our days of, challenges with funding. It's very important to provide the opportunity for follow-up calls to all, callers, and now 988 callers, obviously, who report current or recent suicidal ideation. And this 41% is actually consistent with our earlier 2007 findings, where we found 43% of suicidal callers reported some, any suicidality following their crisis call. And what we found was that callers at more acute risk at the time of the crisis call and those in ongoing mental health treatment were more likely to experience suicidal ideation after the call. And that callers' favorable ratings of, again, these, counselors' engagement with them, connection, collaborative problem solving, safety assessment, safety management, were associated with lower rates of recurrence of suicidal thoughts. Next slide. Some additional findings with regard to counselor practices is that, we had scales for these different counselor behaviors, and that the average score for the counselors fostering engagement and connection was nearly 14 out of a possible 15 score, indicating that the callers nearly universally found their counselors to engage in these behaviors a lot. And average scores for counselor problem solving and safety assessment and management, those scores were also quite high. Other counselor practices that we asked about was whether they had an action plan for immediately after the crisis call and again in the future if the caller became suicidal again. 2/3 of callers reported that they and the counselor had come up with a plan for what they could do if the caller became suicidal again in the future. And this was significantly associated with the caller's perception that the call was helpful and that it stopped them from killing themselves. And this underscores the importance of safety planning. And just to give you an example of the differences in the percentages who reported that the call stopped them from killing themselves, if they had a future action plan, 73.4% reported that the call stopped them from killing themselves a lot. In contrast to 57% of callers saying that if they didn't have a future plan, 57% said the call stopped them from killing themselves. If they did develop a future plan with the counselor, 73% said it stopped them from killing themselves. And both types of action plans, plans for right after the current call and for future suicidal crises, were associated with the caller's perceptions of the helpfulness of the call. Receiving a referral for a mental health, for mental health treatment was not significantly related to any of the outcomes. Again, the outcomes are the caller's perceptions of the helpfulness of the call and whether it stopped them from killing themselves. And the next slide. Okay. We also looked at the impact of the caller's demographic characteristics on the outcomes, and callers identifying as Asian had significantly poorer perceptions of the call's helpfulness. And that this may reflect, just reading off the slide, you can read it along with me, that this may reflect the unique burden that Asian Americans faced during the COVID pandemic. And that's when our interviews took place. And that, unfortunately, we remember that during COVID pandemic, it was associated with China, and then there was a resulting increase in discrimination toward Asian Americans. And so that may really be impacting why the Asian Americans had significantly poor perceptions of the call's helpfulness. And no other demographic characteristics were associated with the caller's perceptions of the call's effectiveness. Next slide. That in light of the data being collected during the COVID pandemic, which was not our plan, that came quite unexpectedly, and we adapted and continued with this study. And I'm glad that had such a devoted collaborators that we were able to do it. But because the interviews were during COVID, we conducted supplementary, what's called sensitivity analyses, to explore whether the three main outcomes differed by callers who reported that stress related to COVID was or was not the primary reason for their call. And we found no significant differences in the recurrence of suicidal thoughts and perceived helpfulness of the call between callers who did or did not report that stress related to COVID was the primary reason for the call. We did find that callers who reported that COVID-related stress was the primary reason for their call, they had significantly higher odds of reporting that the call stopped them from killing themselves. So therefore, we conducted additional analyses controlling for that variable that COVID-related stress was the primary reason for the call, and that we, as I'm saying, again, found no significant differences by that, and so that the association between the predictors and the outcomes that we reported on in the paper and that I reported on today were not impacted by COVID-related stress. Okay, next and last slide. And so with regard to our main conclusions, that the study provides, more empirical evidence for the effectiveness of Lifeline's and now 988 Lifeline's telephone crisis services from the perspective of the callers themselves. That the findings reinforce the importance of follow-up, as I mentioned, and the importance of safety planning. But, the interviews were collected before July 2022 when Lifeline's, when we transitioned to 988. And since then, the 988 network has continued to expand. Trainings for crisis counselors have continued to evolve. So new evaluations are necessary, and new evaluations of 988 are underway. And I'm honored to be part of that evaluation, as is Allison Lake. It's funded by SAMHSA, and it's under the leadership of ICF and Aptiv. And so I think I've stuck to the time. And thank you again for really giving me the honor to present today.
Maddie, and thanks for all of your work. You and I were talking earlier about, we used to call it evaluation 7, and you've lost count. We don't know how many it's been now over the last 20 plus years. Maddie, what did your coworkers think when you moved from psychology into crisis research?
Yeah. So, I'm in the Department of Psychiatry, also in the School of Public Health, but my colleagues in psychiatry, when I started this work in, I guess, was it really? Yeah, 2001. Oh my gosh, yeah. Luckily, I had already been working in, I'm a psychiatric epidemiologist, and I've already been working in the field for about 20 years, which is glad I can still stand. So people respected me, and that was good. And I was a full professor, so that was good. But all my colleagues, boy, did they, we don't want to use the word crazy, right? But they thought I was crazy. They really disparaged my going.
But that was the view of this
but that
work
was the
at the time.
zeitgeist at the time. Exactly.
Yeah.
Exactly. And so happy. I'm so delighted that I was brave enough, and John Califat was, who was such a wonderful partner. And then we roped in John Draper, and
the rest is history.
And we roped in all of the crisis centers, including Jennifer.
Yeah.
So I'm so
Rutgers,
glad
Columbia, Montreal. Hey, let's start with Jennifer Battle. Jennifer, and I see a text in the chat. Great work, Jennifer. And Jennifer, if you come off mute and tell us your thoughts.
Well, Maddie and your team, just change the game for us, we've always known we were effective, right? Like, when we talk to people about our work, we know what's happening, but to have the data behind us, to be able to share that with legislators, with funders, really has gotten us where we are today. And my center's had the opportunity to participate in a couple of studies with Maddie and her team. And it's also just cool for our crisis center people, right, to be part of the history. So love it. Can't wait to see what's coming next.
Thank you, Jennifer, so much. And Maddie, you referenced Dr. John Draper. John, your reflections.
Oh, I have a few, but Maddie, first, thank you so much for your many decades of contributions, not only for this evaluation, but for all of the contributions to the suicide prevention field, to crisis intervention and care services. You have changed the game, and you continue to change it today. And I do wish Richard was also here. I really miss him today. Richard, I know you're not here, but you're always here in my heart. But Maddie and John Califat walked into my life back around 2002 when we were in the first cohort of all of the 8 centers that were being studied at that time. And I was very intrigued by what they wanted to do. They said they wanted to figure out whether crisis lines were effective in reducing suicidality or distress. Now, at that time in New York City, the work that we were doing as a crisis center was really focused on assessment and referral. The idea was that, hey, the real care really happens in offices. It happens in outpatient clinics. It happens in mobile crisis services in your home, perhaps, or inpatient units. But on the phone, really, I was intrigued by this idea. And then, of course, when you announced your findings at AES in 2005, you and John, it was as Jennifer said, a game changer. It was a mind blower. It resonated across the globe in terms of changing crisis services and noting that, yes, in fact, it does. These calls can reduce distress and suicidality, not only by the end of the call, but up to 3 weeks later. I mean, that was a wow moment. But I also wanted to call out a few of your other findings, because you've done a near quarter century of Lifeline evaluations, and a lot of them add up to things that we still need to be paying attention to now. So for example, in your 2012 study, you found that about half of the suicidal callers did not connect to care afterwards. So this is a reminder of us. You mentioned follow-up, that's crucial, but also that this is maybe our only opportunity to help suicidal callers. And another thing I wanted to point out about your most recent study is all of them, those interviews with persons were all before 988 launch. Now, when 988 launched, and since then, we've seen a whole lot of more money flowing towards crisis centers, about 6 times more than 10 years ago. And so with that money comes expectations for key performance indicators, which a lot of them are time bound, about how quickly you answer the phone, how long you stay on the phone, and as many calls as you can answer. When what you found in 2013 in this study of counselors who had been trained in assist for the Lifeline and compared them to the counselors that were not trained, one of the things that you found was that a key factor in the assist trained counselors having lower suicidality rates among callers afterwards. They were more effective in reducing suicidality. And one of those factors was giving them more time to talk. In fact, you found that because they listened to their reasons for dying, which was so crucial to get to the reasons for living, that for every 1 minute that the call was lengthened, the odds, you said, that the callers were less suicidal was increased by 4%. You said, so that meant like 3 minutes longer was the average call for assist trained counselors for suicidal callers, was about 27 minutes as opposed to 24 minutes. And you said that was about a 12% increase in the odds that callers would be less suicidal. So that's a big reminder to us.
So Dr. John Draper, I'm assist trained, but I'm still not going to give you that extra minute more. But look,
it is time. It is time.
There's so much great work, and thanks for taking us. We're going to take one more second for Ted Lutterman, who has his hand up. Ted, maybe we'll come back to you. He's working on the mute button, but it's not coming. So it's under pressure. The puppy went straight into the bush, but he's going to rally and come back. Ted, we'll come back around to you when Maddie, thanks so much for your work. Dr. John Draper, Dr. Madelyn Gould, you guys with Richard McKeon, just a phenomenal journey that continues. And we could do an over under. We won't, but the government shutdown is in week 6 for Crisis Jam. We'll hope to have SAMHSA back with us this coming week. Will be our aspiration and hope. But we do have NASBID with us with the states. And today in the NASBID seat, we have Jess Bounds, Director of Integrated Care from the Missouri Department of Mental Health. Jess, welcome.
Hi, thank you. So just to kick it off, I'm here to talk to you about healthcare homes in Missouri today. So that is the state plan amendment, behavioral health homes. Hopefully that makes sense. So here in Missouri, we adopted a whole person approach way back, and I want to say like 2006 to 2010, when a few studies were conducted. So the first study took a look at individuals with serious mental illness. And the study found that individuals were dying on average 25 years earlier than the general population. Not only were they dying 25 years earlier than the general population, they were dying from chronic health conditions that were not only treatable, but preventable in most cases. So we took another deeper dive and looked at the Missouri population again, those individuals who were receiving Medicaid coverage, and found that 58,000 individuals in Missouri were having $28,000 in Medicaid costs. And of those 58,000 Missourians, 5% of those individuals were incurring half of all Medicaid costs. And what's really interesting about that is of those individuals, 85% of them had a mental health diagnosis. I know these are a lot of numbers, but basically what I'm telling you is a high number of individuals who were receiving Medicaid coverage had a behavioral health diagnosis and prescription, but no doctor's office visits. So what that means is they were going to the ERs, the hospital, and receiving care, but not long-term care. So Missouri said we need to change our system. We started serving individuals with the whole person approach. Like I was saying, we're bridging that gap between physical health care and mental health care. And over the years, what we found is we're reducing avoidable hospitalizations and decreasing emergency department visits where emergency department care was not needed. And we were doing that again by serving that whole person. Next slide. And so when we say serving the whole person, what we really mean is we're adding a doctor and a nurse to that behavioral health team. So we saw individuals with schizophrenia having a 61% decrease in their A1C, their blood pressures were decreasing, cholesterol was going down, and these small movements in cholesterol going down, blood pressure changing, we're reducing strokes, heart attacks, and just all kinds of diabetes related complications. And so what that means, next slide, is in the first slide I was talking to you about, in 2006, that study that found individuals with serious mental illness were dying on average 25 years earlier than the general population. We recently redid this study, and we have found that we are adding those 12 years of life back to individuals. And so instead of dying early at the age of 50, which we know isn't even possibly considered old, right? They're now looking at a life increase of 12 years. And so this is a really big deal, and we're excited to share this information about what is happening in Missouri. I forget what my next slide is. So if you want to go to the next one. Nope, that's it. That's what we got. So,
Jess, thank you so much for the work you're doing. There is some questions in the chat. If you would jump in there and follow
awesome.
up, we'd appreciate that.
Sorry, the first question looks to say, did Missouri look at how many of these individuals were unhoused? At this time, we did not split the data in that manner. Yeah. But if you want to follow up, we possibly could. We do track that type of demographic information in our system. So we haven't just sliced it that way yet.
Great. And I'd encourage you to get into that chat. And Maddie as well, there's some questions I don't think we quite got to. And John Draper, this history is just so vital. I think some of the other talking points, would love to see those in the chat as well. Ted, we're going to take another shot and go back to you. Do you have a comment with Maddie that we want to get back to, Ted? Let's go to Dr. Chuck Browning then. Dr. Chuck.
Speaking of tech, I think Ted's got the how AI taking over his topic in.
Yeah, I've had that a number of times myself. So, Behavioral Health Link is a sponsor of the Crisis Jam and has been helping us with driving forward the concepts. And this idea of all feelings welcome really is an extension of what came out in season 2 of Crisis Care that feels like care to the individual. So this is really an effort, and the t-shirt I was referencing earlier is very much trying to get that across. But all feelings are welcome is dependent on a certain context, Dr. Chuck. And you wrote a blog about that culture, that approach that we're going to put in the chat. But gotcha versus got ya, they sound similar, but they're different. Tell us about what you wrote in the blog, Dr. Chuck.
Well, David, I got really inspired by the fireside chat with Dr. Jack Rozelle, as well as a lot of the work on the American Association of Emergency Psychiatry listserv, where we were discussing some of the literature about this concept. And the title of that fireside chat, for those that might not have been there a few weeks ago, was Beyond the Checklist, Engaging with Risk. And thinking about how, as Maddie shared today, sharing saves lives. And yet, across our country, parts of our crisis continuum, we obviously know by the literature and by the research that up to potentially half of people with suicidal thoughts often don't feel safe because of fear of coercion and other things. And thinking about that inspired me to write this piece to really reflect on this concept of, in our call lines, we do have a better job, I think, of saying got you to people that are struggling with suicide and with risk, being able to share it, proactively engage with the people that they're talking to and get support and do better. And that through the rest of our continuum, that there is a lot of risk of liability focused kind of gotcha. And that pressure is gotcha on the person who is talking about their risk, as well as the staff members who might be fearful of liability. And so talking about a best care ideal system to think about for our learning community to develop and throughout the whole range of the continuum, even through follow-up. And then thinking about, because it was through BHL, how technology can aid that. And so we created some pieces and reflections on some of the key elements that technology can make a difference in helping us say, got you. So it's in terms of decreasing documentation technology, as we've been showing in multiple different apps across the Crisis Jam learner community, can help the staff person focus on engagement and eye contact, and then be able to translate nuanced decisions and things that they're picking up, but not as much about prediction, just being able to help them turn the what's that they're hearing about into how you can turn that into safety planning and safety things. We feel like it makes a big difference in terms of support, having the potential to support best practices. And then also talked about technology being able to help with continuity of care, so that that same got you feeling can be translated from a call to a mobile team, to a safe place for help, or to a follow-up, and being able to keep that embrace and sharing that information and what's working for that person from group to group in the continuum. And then finally, just having tech to be able to help with quality improvement, AI being able to help support more listening to all the calls down the future, being able to help have system management of how well the system is creating care that feels like care and makes it safe to share. So I appreciate being able to talk about it, David. It was a very meaningful thing to write to me. I just had my wife's cousin is a college student and endorsed suicidal thoughts in another state, and had no intent and no plan, and ended up hospitalized against her will for 3 days, despite having really good resources and folks who would help her be able to connect to things. I sent this article, and he was like, "Oh my gosh, this is exactly what happened." So it happens all the time in real life, and it's just it was amazing that happened at the same time as you asked me to talk about this today. So thanks.
Yeah, thanks, Dr. Chuck. And look, Maddie led us down this path of crisis being the service, not the connection to the service. And all of those services are important, but the impact we can make, and to the extent that this can roll out into our mobile crisis, into our facility care, just makes a huge difference. So thanks so much. Next, we're going to go to Voices in Crisis Care, and we're going to bring in Dr. Chris Drapeau from Vibrant. Chris, are you with us?
Yep, I'm here, David.
Chris, you and I worked together on the 2019 AAS conference. You were the program director, the guide, my clinical medical research guide to this work. You had the concept of convergence. We brought in Dr. Robert Sapolsky. Fun stuff. But today you're here to talk about the National Council for Suicide Prevention and the data that John McIntosh and team have created year to year, and in particular to talk a little bit about some of the myths and what they mean and don't mean. So Chris, tell us about the data.
Yeah, I would love to, and definitely want to give a shout out to Dr. John McIntosh. He began compiling national suicide mortality data back in the 1980s, and it was a privilege to start joining him on this project in 2012. And so if any of you are interested in knowing what is going on trend-wise for suicide ideation, for even deaths based on temporal factors, we have a number of resources here that might be of interest to you. There's two things I'd love to point out to this group, given the work you do on the ground in your communities. The first is that, given that we're in November, the holiday suicide myth is going to come up if it hasn't already. And this is the belief that suicides peak around this time of year. There have been a number of studies that have pushed back on that and suggest that's not the case. And a lot of these are based on doing aggregates of national mortality data, and as you can see here, showing which months are highest or lowest based on averaging the number of days per month. So you're standardizing it across those 12 months to see, okay, where are suicides most likely just based on averages. And what you can see here is pretty consistent year to year when you look at the national picture, is November, December tend to be low. And so what we did for the National Council is we did a 25-year aggregate of all suicide data. And then we looked at all the racial ethnic groups that were available via the CDC Wonder database. And what we found is when you do the 25-year aggregate, December comes out as the lowest ranking month. But it's a very different story if you look at year to year. So it's very important that when you're talking about suicide prevention around the holidays, that you don't assume that it's going to be low everywhere, because the suicide myth may be true in some areas of the country. Because what this graph should show you is that suicide happens every single month. And when you look at these resources, you'll notice for some racial and ethnic groups, sometimes there are years when December is top 5 instead of number 11 or 12. So it does vary year to year. So please be vigilant about that as you're having suicide prevention conversations. Also, I want to point out this is an unavoidable limitation of death investigations that we just have to live with. And David and team, I think this is important to keep in mind around any temporal analyses of suicide, is that we don't know how frequent it is that the timing on death certificates, is it based on the actual timing of the suicide attempt, or is it based on when the person who died by suicide was found? That's critical. If you look at day of week analyses, Monday is always number 1. That always has the highest average number of suicides every year. But that could be because that's when people are most likely to be discovered if they died by suicide over the weekend. And there's no way, there's not an exact science to know exactly when they attempted. So that is a crucial, crucial caveat to keep in mind as we're interpreting these data and as you talk in your communities.
Wow. So, Chris, thanks so much for your leadership and continued work in this. Maddie, we've got just a quick second. John Califat, what you raised was your partner from Rutgers, and this work that Chris and so many others have been talking about. Give us a couple of words about John and his impact.
I can't say enough about how much John really changed the landscape as well. You know, he died in 2007, quite suddenly, and we, had developed such a great partnership. You know, at the time, he had a long-standing expertise in the area of, crisis services. I was, a methodologist, but a relative newbie to, the crisis centers. John had run a crisis center for years and years, and I believe St. Louis. And so he had, the vision to start evaluating, crisis centers as well. Yeah. And as a little tidbit, it was actually Lanny Berman who was the matchmaker for both of us, because John and I were going to be competing for the evaluation
and you ended up becoming partners.
We became partners, and
Chris Drapeau, we want to get John McIntosh on as well, and we'll do that as we go forward. So thanks so much to Maddie and Chris for the work you're doing. And Kristen, take us home.
Thanks, David. And like others have said, big thanks to Dr. Madelyn Gould for your decades of support and everything. And today's conversation, I learned a lot about the evaluation. Huge shout out to our headliner sponsor you just saw, AHP, and earlier we heard about Behavioral Health Link, one of our opening acts. We are still looking for more folks to join. If your organization wants to be part of it, reach out. Please don't forget, on your screen you see Crisis Now 4 is going to be in Washington, D.C. in July of 2026. We can't wait to see what the next wave of innovation of collaboration brings globally. Next week, we have Debate 9 with Paul Galdis and Dr. Joe Parks, tackling whether states should build capacity in the 3 core crisis services. In 2 weeks, we have a fireside chat with Sophie Shev and Michelle Zabel. And then the following week, we will not have a jam. We want you all to enjoy your Thanksgiving week, time to rest and refuel. Again, we always want to thank you for watching. Please tune in, log on, join the movement, and we will see you next week.